Hello everyone, this is Dr. Nousheen. We are starting with another topic from behavior and psychiatric problems in children's, okay? So this is a case of 10-year-old boy with bedwetting. When we take the history, there is no medical problem, no recent illness. The child is healthy. So this is the case. Let's talk about this case. And in this scenario, the child's siblings also, the 12-year-old sibling also suffering from this, okay? So this is a case of bedwetting. Okay, so what is bedwetting or nocturnal enuresis? With definition, you need to know that this is the involuntary or voluntary repeated discharge of urine into the cloths or bed after the developmental age. Okay, so what is the developmental age? Developmental age is 5 years. Okay, so after the developmental age, child have this problem. Okay, usually after the developmental age, the bladder control should be achieved. Okay, but in this case, the bladder control is not achieved. When we defined that is the bladder control is never achieved, like the urinary control never achieved, it become primary. Okay, it's from the start, so it's usually 70 to 90% cases. But if there is a short period of dryness, like for few months, usually 6 months, okay, 6 months dryness, there is no bedwetting even a single day for 6 months, and then restart enuresis. Okay, so then again enuresis develop. So this is the cause secondary. Okay, there is some other causes which trigger this. Okay, the child becomes fine and then again started this problem. So you need to think about the causes. What is the cause? Okay, this becomes secondary. Okay, so now what is the risk factors in epidemiology? If we talk about the gender, that's more in children's boys. Okay, 60% boys have 60%, 60% boys have this problem. But when we talk about, like, there is like you have a 10 scenarios and you are talking about the genetic predisposition, or is it primary or not. So 50% families have this problem. So 50, when you talk about the family history, it becomes 50% have family history positive. And if we talk about the gender base, you will say that it's more in boys. Okay, now what is a cause? As we say that a 50% case is like genetic. Okay, that there are other causes like hormonal and bladder factors. Let's talk about this one by one. In a normal child, what happens at night time, there is a hormone which is called ADH, antidiuretic hormone, is levels becomes increases during night. And what this hormone will cause, it increase water absorption from the nephrons, increase water absorption. Okay, from kidney or from nephron. Okay, during night time the levels increases, or you can say that, or other word you can say that it concentrates the concentrate urine. Okay, when the urine becomes concentrated, the volume becomes low. Okay, so this is the main task of ADH at night time in normal child. But what happened with a child with bedwetting? Some childs have this ADH production becomes low, which results in polyuria, because when the ADH low, the urine becomes diluted, becomes more in volume. So that's called nocturnal polyuria or increased urine output. Okay, so this is a hormonal case. And when we talk about the bladder factors, like, there is a bladder capacity. Before talking about this, there is normally what happens. There is usually a normal bladder capacity according to the age. When the bladder fills, the muscles have some receptor which stretches and gives signals to the brain to wake up. Okay, so brain gives signals to wake up for washroom, for urination. Okay, so what happens in those child, there is lack of inhibition, means there is a receptor stretching, There is a brain give signal, but the brain will not give respond. Okay, brain will not give signal for wake up. Okay, so this is lack of inhibition. And you know what is bladder capacity? Normal bladder capacity. Before talking about that reduced functional capacity, we need to know about what is the bladder capacity. So bladder capacity is, we are talking it with the formula. There is a formula like that: years plus 2 into 30. Okay, if the child age is if the child age is 6 years plus 2 into 30, it will become 240 ml. So at the age of 6 year, the bladder capacity is 240 ml. We can say the child age is 8 years, so at the age of 8 years, the capacity is 300 ml. At the age of 10 years, the capacity is 360 ml. Okay, that's the normal scenario. But some child have reduced functional capacity. Their capacity is low, maybe 150 ml, maybe 100 ml. So at 100 ml, the bladder, although the bladder looks normal, there is nothing structural problem, but their capacity, functional capacity is reduced. Okay, at 150 ml or at 100 ml or at one whatever there is, we can say that it's usually the from the normal capacity less than 70%. No, if it is less than 70% the bladder capacity, this is the reduced functional capacity. Okay, normally if it is 250 ml, so you can say that if 70% feels, it is reduced functional capacity. Okay, if it should be less than 70%, then we label it as reduced functional capacity. Then child feels to urinate. Okay, but the child is sleepy, child will not wake up. Okay, so because of the deep sleep. Okay, so this is it, you know, this is like there is no stretching occur, there is no brain signaling occur, but the child's voids. Okay, so this is reduced functional capacity. And on this regard, we can say that the volume is low. Okay, and there is an overactive bladder, means that even at the 100 ml, the muscle stretches and it's contract. Okay, the muscles even contract at 100 ml even with a low volume. Okay, so this is overactive bladder. Both in reduced functional capacity and overactive bladder, the volume, bedwetting volume is low. But when the case is hormonal, the urine is dilated. Okay, so the volume is more. Okay, so you can differentiate between hormonal and bladder factors. You can differentiate between two. Okay, now how will you take the case? For any case, you have to take the history. Any diagnosis need history. Okay, and history give you the clue. 80% diagnosis you can make with just history, right? You can take the family history. Is the parent sibling have this problem? You have to check whether it's primary or the secondary cause. You need to check the symptoms like frequency, how many times it's occur, urgency dysuria, that will give you the clue of UTI, that is urinary tract infection or not, or dribbling. Okay, so these are symptoms with urinary tract infection. Okay, you have to check some others conditions. A child is okay, but the child's have this problem, so you need to think about that, is there any constipation or not. So you take a proper detailed history for each and every part, so you, if you diagnose properly, you can manage properly, right? So there is some social psychosocial problems, like the child is in stress, or child have child abuse or other problems that also lead to incontinence, right? So you need to take the history of all this. Okay, so this is the differentials. You must have differentiate between either it is diabetes insipidus, diabetes mellitus, chronic renal disease, whatever. We are not talking about this is primary. This is the cause. You need to rule out the causes. Maybe this is not the incontinence, maybe because of diabetes insipidus. Okay, in diabetes insipidus there is ADH becomes low. Okay, there it results with polyuria. There is a polydipsia means that increased thirst. Okay, What is diabetes? How will you rule out the, and in diabetes insipidus, the urine specific gravity is low. Okay. What is urine specific gravity? It will tell you about the urine specific gravity will tell you about the concentration of the urine. So urine concentration is low. In diabetes mellitus, you will see in urine analysis, you will see glucose become positive. Okay. And chronic renal disease, you have to rule out, is there any functional problem or other problem? Maybe the kidney is continuously making a dilute urine, no, with no other problem, the kidney function is not fine, so you need to rule out these problems. Okay. Now, what is, you have to check after the history ruled out, you have to check the physical examination about the neurological. If it's because neurological with the lower spine, it results in uh, incontinence. The rectal for constipation, you have to check the general assessment. Genitalia, you have to check for males because maybe some genetic problem like hypospadias. What is hypospadias? Is basically the birth defect with urethral opening is located underside of the penis. Okay, so this also results in incontinence. You have to do this physical examination. And in our case, we discussed previously, the child sibling have this problem, so there is a positive family history with normal everything, no culture is negative, specific gravity is fine, and no medical illness. So our case is primary nocturnal enuresis, right? Now, okay, so what is the management? We are talking about the management in general. The first and the foremost is reassurance. You have to reassure the parents that this condition is self-limited. Okay, no need to worry about this case is self-limited. It will resolve its own with some approaches like behavioral. There is a conditioning and pharmacotherapy. We will talk about each one by one. Let's start with reassurance. What is reassurance? Reassurance is we're done with reassurance, right? Let's talk about behavioral. Behavioral approach means that you need to change the behavior. What's the behavior? Decrease intake of water or fluid after 7 p.m. Okay, decrease intake. And the second thing is that excess sugar and caffeine after 4 p.m. Okay, after 4 p.m. cut out. No chocolates, nothing sweetness, or no caffeine after 4 p.m. and must wipe before bed. Okay, so this is the behavioral approach, and if it's not work, this is the start after the reassurance. And the second thing is that conditioning. What is conditioning? There is a basilar alarm you have to put under the child's bed, and when the bed wet, the alarms buzz. Okay, and the child wake up. So at the time, the child will learn the proper timing for waking up. Okay, so this is the way to, like, this is conditioning therapy is usually done for arousal therapy, like the signals from the bladder goes to the brain, but the brain not wake the child. So if there is a arousal problems, so this conditioning therapy will help. And there is another approach which is called pharmacotherapy. Some child need medicine. No reassurance, no behavior, even not the conditioning will work. So start with some desmopressin medicine, which is ADH, synthetic analog, which increase the concentration of the urine, reduce the volume of the urine, and you can give at the bedtime. And this is safe but have relapse when you stop. Okay, so the dose is this. Okay, so this is the first dose, the medicine you can give. The other medicine is anticholinergic, which is oxybutynin. Okay, this anticholinergic medicine usually beneficial for overactive bladder. Okay, because it relaxes the smooth muscles and it reduces the pressure. Okay, so this is for overactive bladder. Okay, overactive bladder, right? Now, the third medicine is, this is a third line approach. When the desmopressin, the anticholinergic will not work, you have to give the third line tricyclic antidepressants. Okay, this is mainly because maybe the child have stress or abuse problems. So this is a dose for 6 to 8, 25 mg, more than 8 years 50 mg. This is the third line. It has side effects, but if nothing will be beneficial, so you have to start with this. Okay, this is all about nocturnal enuresis. If you like my video, you learn from me, so take home message. We will revise it quickly for about the management. Reassurance that this condition is self-limiting. Child have this problem not only just with your child. Then you start with behavioral approach. Stop the fluid after 7 p.m. No sugary food, caffeine after 4 p.m. Do conditioning with buzzer alarms. You have to do some medicine like desmopressin, anticholinergic, and tricyclic antidepressants. Okay, one by one, if not work. Okay, so do support me. We will meet with another lecture. Okay, thank you. Bye.